So let's start with the upper esophageal conditions. There's a few you need to know, and we're going to start with the esophageal web and Plummer-Vinson syndrome. So an esophageal web, all that is a protrusion of the esophageal mucosa into the lumen. So that just looks like if this is our esophagus, we have a little bit of tissue that's sticking out into the esophagus, okay? And how this will present, you might get dysphagia to poorly chewed food. They'll have to specify that for you to start to think about this. And that makes sense, right? If you're able to chew your food well and you have little tiny fragments, that can pass easily. But if you don't chew well, then you might have a big bolus of food that gets stuck on that web. And the complications of this, there's a few different things. And the one I'm going to kind of hammer home for a few of these conditions is that if you have constant irritation, your risk of squamous cell carcinoma will increase. Remember, we're still in the upper esophagus, which is part of our non-keratinized stratified squamous epithelia. So if you're going to get inflammation to that tissue, you're likely to get squamous cell carcinoma as a result, and this inflammation can cause that. Here's an esophageal web you can see right there. I've tried to highlight it. And we'll move on to Plummer-Vinson syndrome because this actually is a syndrome that has esophageal webs as one of its classic symptoms. So we don't know everything about Plummer-Vinson syndrome, but it seems like it has to do with nutritional deficiencies, and there might be some autoimmune component to it as well. And how this presents is that they'll always give you this classic triad on tests. The first one will be esophageal webs, as we've just discussed. You'll also get dysphagia, which makes sense. You'll have trouble swallowing because of the esophageal web. And then you'll get iron deficiency anemia, and you'll also sometimes get glossitis. I don't want you to forget that one, but the classic triad is the webs, the dysphagia, and the iron deficiency anemia. Now, those seem random, and so how I want you to think about this is I want you to think of Plummer-Vinson syndrome as a very severe nutritional deficiency, and I'll explain what I mean. So obviously one of the three components of the triad is iron deficiency anemia, so it makes sense. You're already iron deficient. And there's some evidence that the formation of esophageal webs, at least some of them, are actually formed because of as a byproduct of iron deficiency. You get this mucositis that's inflammation of that area, and it can form a web. And that all might be related to a nutritional deficiency in the first place. And we've talked about this in the oral cavity section, but glossitis or inflammation of the tongue is often due to either iron deficiency or B vitamin deficiency. And this is actually from our oral cavity lecture. I discussed right here that iron deficiency, B12, B3, B6, B9, B1, I don't want to forget about that. All those deficiencies can cause glossitis in some way. So it kind of makes sense that all these things, even though they seem kind of random from each other, they actually are combined by this nutritional deficiency. And now treatment for this, it should make sense. If we have a nutritional deficiency, how do you think we should treat it? We should give them the nutrients they need, and that's usually iron. And complications of this, we already discussed this, but anytime you have an esophageal web or any sort of chronic irritation to the esophagus or any part, I want you to think throughout the GI tract as we talk about these things. Anytime you get chronic inflammation or chronic irritation, that's almost always going to increase your risk of having some sort of cancer down the road. So now let's move on to Zenker's diverticulum. So this is a lower pharyngeal or upper esophageal outpouching of the mucosa, and it's caused by a defect between the thyropharyngeus and the cricopharyngeus muscles in Killian's triangle. I know that seems really low yield, but I gotta tell you, they love to test this stuff. So just keep this in mind. So on your left, you can see this outpouching that I talked about. That's a diverticulum. And now on the right, I'm going to show you exactly where they like you to know. So they want you to know each of these muscles, and they want you to know Killian's triangle. So here's our thyropharyngeus in blue. Below that, we have our cricopharyngeus. And then in between those two, you have something called Killian's triangle. And sometimes if there's a defect there, a little bit of a weakness, you can actually get the tissue to push right through there. And you can see the diverticulum on the outside there. And how this will present, it's usually somebody who's very old. They're gonna have trouble swallowing, and they're gonna have really, really bad breath. I've never seen a question on Zenker's diverticulum where they didn't mention halitosis. And that kind of makes sense that food's getting stuck in that diverticulum instead of going all the way down to our stomach, and that food can start to spoil in that specific area. And you could also get a sensation of food stuck in the throat. That's also seen a lot on tests. And uh, also vomiting of undigested food for the same reasons we just talked about. I think halitosis of these three is really important, but I got to be honest, I've seen each of these on test questions pretty often. And they do like you to know if it's a true or a false diverticulum. And let me talk about what that means. How I remember this is a false one is that the Z in Zenker's, I think of Zenker's for falls to remind me. We're going to see this in a few different lectures, so it's good to kind of go over what a true diverticulum is and a false diverticulum. From our GI intro series, we talked about the different layers of the GI tract. We have our lumen, our mucosa, our submucosa, our muscular layer, and then we have either the serosa or the adventitia, depending on where you're at. And then in this case, I just wanted to go over what the difference is between these. So in a true diverticulum, the outpouching involves all four layers of the GI tract. So what that would look like, or actually, let me put these on the board first. A false diverticulum does not involve the muscular layer. Okay, so now let's talk about the difference between them. So in a true diverticulum, all four layers are involved. And so what that's going to look like, the outpouching will still contain every layer. Whereas in the false diverticulum, because the outpouching is actually breaking through a weakness in our third layer, this layer right here, it's actually going to break through this layer. And let me show you that right now. It breaks through this layer and we don't have that as part of this diverticulum. So it's a false diverticulum because all four layers aren't included. And something I wanted to point out with true diverticula, you can see that our appendix is a true diverticulum. And later on when we talk in either the small intestine or colon, we're going to talk about Meckel's diverticulum, which is also a true diverticulum. And the false diverticulum, as you can see, this layer is not included in it. That's going to be seen in Zenker's diverticulum right now, as well as diverticulosis, which we'll talk about in the colon section. Let's talk a little bit about esophageal stricture. It's pretty straightforward. It just means a stricture is just a narrowing. So this is an abnormal narrowing of the esophagus. And this usually happens because of chronic inflammation that leads to scarring and stricture. So if I draw our esophagus here, if you imagine there's some inflammation, sometimes our body can just handle, most of the time actually, our body can handle that inflammation and recover properly. And then you don't have any problems, you're good to go. The problem is, especially in the setting of chronic inflammation, sometimes you'll have inflammation and then that'll turn into fibrosis and scarring. And sometimes that scarring has contractile tissue that can actually bring the tissues together and you'll get these strictures, these narrowings. And we'll see this in a few different diseases like Crohn's disease as well, primary sclerosing and cholangitis. It's the same idea where you just have this chronic inflammation that ends up kind of causing this fibrotic tissue that brings stuff together. And so this is caused by inflammation. That's the main cause. So esophagitis. And of the forms of esophagitis that we'll talk about later, acid reflux is the most common cause. You can also get it through something called caustic ingestion, of lye. And I want to talk a little bit about this. I don't remember this being tested in step 1, but it is step 2 fodder, so it's useful to know. So anything that's caustic just means it can corrode organic tissue. So it's really, really dangerous to ingest this. And usually it's ingested during a suicide attempt that's incomplete. And the complications of this is that because you have this inflammation and these strictures and this really, really dangerous substance, it could actually lead to strictures as well as squamous cell carcinoma. And what they like to do on tests, they like to trick students who know the association between lye ingestion and squamous cell carcinoma and give them a trick question. And I'll show you what that means. If you ingested lye, it's not like you're going to get cancer overnight. You're not going to get cancer even 6 months or a year later. It takes around 40 years on average from when you ingested lye till when that squamous cell carcinoma develops. So on tests, they might give you, hey, this person ingested lye. 6 months later, they're coming back. What's wrong with them? And they'll put squamous cell carcinoma as an option, but it's way too soon for that to develop. If that's the test question, the answer is going to be esophageal stricture because that can happen pretty quickly. So we've talked about some of the risk factors for squamous cell carcinoma already. We've talked about esophageal web, esophageal stricture, anything with chronic inflammation, lye ingestion, um, anything that's caused irritation or inflammation in the past can cause squamous cell carcinoma. So let's go over that. Obviously, that's a cancer of the squamous cell epithelia that we've been talking about. This right here. I'm not going to bug you guys with all this again. So if this all gets, gains mutations over time, it can cause cancer. It's the most common esophageal cancer worldwide, but only the second most common in the US. So adenocarcinoma is more common in the US. And it usually happens on the upper 2/3 of the esophagus, which again makes sense because our lower 1/3 of our esophagus is normally either, it's usually a big portion of that's already simple columnar epithelia, or it has transitioned to simple columnar epithelia through the process of metaplasia. And so what causes this? Chronic irritation. I don't know how many times I have to say that, but I really want to drive that point home. That could be irritation through tobacco, through alcohol, hot liquids. That's one of the reasons why it's more common worldwide as well. And caustic ingestion. But remember, there's a really, really long time difference between when you ingest it and you actually get it. And then there's quite a few conditions that can irritate your esophagus that can cause it. We've already talked about the webs, we've talked about Zenkers, achalaisias here, which we'll talk about later, that can also cause chronic inflammation of that area. And as with most cancers, you're going to get weight loss. This is really important, this progressive dysphagia. Because the cancer is slowly growing through the lumen, you're going to have solids affected first, and then liquids eventually as the cancer takes over more of the lumen. Odynophagia, it's probably going to hurt to swallow, especially if the cancer is invading into local nerves. You can get hoarseness for that same reason. And on histology, they do like you to know this. For any squamous cell carcinoma, you need to know that there are malignant nests as well as keratin pearls, okay? So this picture is great because it has both of them in there. I can show you the malignant nests here on the left. You can see how they look angrier than normal, but they're actually pretty structured. There's like a nice nest of these cells right here. And then the keratin pearl is the most obvious you're going to see on the test. If you ever see something like this on the test, this big keratin material, especially if somebody has risk factors for cancer, I'd be highly suspicious of squamous cell carcinoma. The last thing I'm going to talk about is a more of an embryonic or early childhood disorder. It's going to be the tracheoesophageal anomalies. So how this works is you have defective formation of your esophagus in utero. There's 3 different subtypes to this. You can get pure esophageal atresia, you can get pure fistula, or you can get a combination of both. And let me show you what that looks like. So if this is our esophagus and this is our trachea, what's going to happen is that you can get a pure atresia, which just means there's just a blind pouch, and there'd be no possible way for you to get food into your stomach this way, because there's no possible connection between your distal esophagus and either your trachea or your proximal esophagus. You can get a pure fistula where both ends of the esophagus actually divert into the trachea and form a fistula. But most common is this esophageal atresia and a fistula. So you pretty much have this blind pouch here, but then in order to get any sort of food into here, your body has formed this fistula from the trachea. So the trachea can actually get food somehow into the stomach, but that's still not good for you, and as we'll see in a second. So how does this present? Well, in utero, you're going to have somebody with polyhydramnios. So polyhydramnios means extra fluid, amniotic fluid. And the reason this is happening is because normally in utero, the baby is able to drink the amniotic fluid and then it pees it back out, right? So you're going to get polyhydramnios because the baby cannot drink any of the fluid in, so it's stuck in the cavity and it grows. In a neonate, you're going to get failure to swallow or vomiting during feeds because there's no easy connection between our oral cavity and our stomach. You can drool, you can choke, and you can also get cyanosis, so you can turn blue because of laryngospasm. And that kind of makes sense, right? If you have all of this acidic, bad, or foody material coming into your trachea, threatening to go into your lungs, your body's going to compensate by constricting that whole area, and you're not going to get as good of lung ventilation, and you're going to have cyanosis. On a chest X-ray, you're going to see two things. You can see a gas bubble or air in the stomach because of the tracheous connection, or you're also might see an inability to pass an NG tube into the stomach. And so both of these are accessible in this picture here. We have a big air bubble right here in our stomach, and then an inability to pass an NG tube. If you look at the top of this X-ray, you can see how the NG tube's not passing down like it normally should all the way down in. It's getting kinked up here because there's an atretic proximal esophagus that's preventing it from going all the way down. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.